Do you have symptoms in your urogenital area that are driving you up the wall? Have you consulted one doctor after the other and no one was able to find the reason? Then you might consider watching this video because your problems could be related to muscle tension. Welcome to UroChannel. My name is Stefan Buntrock and I'm a urologist. UroChannel is all about urology and beyond because sometimes it's just not enough to cover the core curriculum. Just because symptoms happen to be located between the legs doesn't necessarily make them part of urology. And even if apparently nothing can be found, that doesn't mean it's not there. On UroChannel, I share with you my experience as a professional. My content is about the normal stuff. And I talk a lot about those white spots on the urological map, hoping that maybe someone someday will watch one of my videos and gets the one piece of information that was needed for progress. So if you like my content, please subscribe to my channel. One of these white spots is chronic pelvic pain, also known as CPPS. There are different types of pain. Some are easy to treat, but chronic pelvic pain is not. Pelvic pain contains a variety of symptoms, and not all of them would fall into the category of pain for most people, strictly speaking. But there are symptom clusters that can be observed with the different pain syndromes. Urinary urgency may be one of those symptoms, or testicular pain, or pain at the tip of the penis, or a burning sensation with urination, and lots more. Now, the problem is that many of these symptoms are non-specific and can be related to a whole bunch of different diseases. As a doctor, one has to rule out inflammatory and infectious diseases, as well as sexually transmitted diseases, stones, prostatic diseases, strictures, neurological conditions, cancer, metabolic diseases, hernias, and much more. The ones who are left are those patients where apparently nothing can be found physically. In these cases, doctors are quick to put them in the psychosomatic corner, and this might be a reasonable explanation. But what if it was a problem they didn't find just because they're not trained to look for it? Because one would have to look for muscle function, not for organs. In urology, we have this condition called chronic non-bacterial prostatitis. The more patients I see, the more I believe that this disease has to be redefined, as there are many patients with pelvic floor issues who fall into this category. Experience suggests that it is not the organ, the prostate, which causes the pain, but a tight pelvic floor. By the way, also women with pelvic pain come into my office, and some of them complain of symptoms suggestive of chronic non-bacterial prostatitis. Only women don't have a prostate. Here's a summary of symptoms that are suggestive of a pelvic floor disorder. And remember, any other urological disease has been ruled out to this point. Pain that varies in intensity throughout the day, that is influenced by posture. Some patients report that deep squatting gives them relief. Shifting testicular pain, a constant burning sensation at the tip of the penis, constant urinary urgency, post-micturition dribble in young age, residual urine without obvious cause, weak urinary stream without obvious cause, a burning sensation at orgasm and ejaculation, erectile dysfunction, constipation, history of hemorrhoids, bilateral varicocele, sensation of a tennis ball between the legs. These are the most common. In examination, trigger points are suggestive of myofascial pain. Trigger points are painful spots in the muscle. When pressed upon, they hurt. In pelvic pain disorders, they can be found in the abdomen, typically at the edge of the oblique and rectus muscles. In rectal examination, patients with an overactive pelvic floor may exhibit a tight sphincter tone and tight pelvic floor muscles. And even here, I frequently find trigger points. How do I know that I'm on the right track? Because I see results when I treat muscle, not organ. But it would be far too easy if everybody was helped with that approach, wouldn't it? The majority gets better, but there are still some patients left who don't respond to treatment. What about them? Am I doing the right things at the wrong place? Or is there such a thing as chronic non-bacterial prostatitis, but only for a limited subgroup? Hit the like button now and subscribe to my channel, and I will see you in the next video. Bye bye.